Mena Foot Ankle Institute, where today we will be talking about plantar fasciitis, a leading cause of heel pain worldwide affecting both the general population and athletes, particularly the runners. It is a common cause of chronic foot pain and significantly impacts mobility and quality of life. Today, I will explore the anatomy, pathophysiology, clinical presentation, diagnosis, and treatment options for plantar fasciitis in a comprehensive manner. My goal is to provide a high yield, evidence based understanding of this condition to optimize both conservative and surgical management. So let's start with the basics, the anatomy. So the plantar fascia is a dense, fibrous connective tissue that originates from the medial calcaneal tubercle and extends distally to insert into the proximal phalanges. It consists of three bands: the medial plantar fascia, which is highlighted in purple, the lateral plantar fascia, that's highlighted in light blue, as well as a central band, which is the most clinically relevant, and combined they are called the plantar aponeurosis. A high yield point is that the primary function of this plantar fasciitis is the arch stabilization and shock absorption during gait. During toe off, dorsiflexion of the toe tightens the fascia, raising the arch, a biomechanical function known as the Windlass mechanism. Excessive mechanical loading or poor foot biomechanics can lead to degenerative changes and micro tearing at the fascial origin, predisposing individuals to plantar fasciitis. Now, from a biomechanical view, the plantar fasciitis is primarily caused by chronic overload of the plantar fascia. This results in microscopic tears near the calcaneal insertion, triggering a degenerative rather than an inflammatory response. And a high yield point is that the histological plantar fascia resembles a tendinosis rather than a tendinitis, meaning that the collagen degeneration and the disorganization are the primary issue, not the acute inflammation. And the biomechanical abnormalities, such as excessive pronation, high arch foot, tight calf muscles, exacerbate the stress. Additionally, obesity, increased strain, while improper footwear, such as shoes with poor arch support, can worsen the symptoms. Now let's look into the underlying issue. The most common cause of plantar fasciitis is the repetitive stress and mechanical overload. This is why it is frequently observed in runners, athletes, and individuals who stand for prolonged periods of time. A high yield point is the pes planus, also as flat foot, increases tension on the plantar fascia due to the excessive pronation, while a high arch foot, or pes cavus, leads to a rigid foot with poor shock absorption. Both foot types are at risk for having plantar fasciitis. Other factors, including tight Achilles tendon, which restricts dorsiflexion and increased plantar fascia strain, as well as obesity, which adds excessive load to the foot structure. Now let's look at the risk factors. Plantar fasciitis is most common in individuals between the ages of 30 to 60 due to progressive loss of collagen integrity and tissue elasticity. A high yield point is diabetes is a significant risk factor because it leads to collagen glycation and poor tissue healing, making plantar fasciitis more chronic and resistant to conservative treatment. Additionally, individuals in high impact sports or occupation requiring prolonged standing or at a higher risk due to increased repetitive strain on the plantar fascia. Now let's look at the symptoms. Patient describes plantar fasciitis pain as a sharp, stabbing discomfort localized at the medial plantar aspect of the heel. A high yield point is that the hallmark symptom is a post-static dyskinesia, meaning the pain is worse in the morning upon the first few steps out of the bed. This occurs because the fascia tightens overnight and stretches abruptly when the weight is placed on it the next morning. Now, upon physical examination, you can find tenderness at the medial calcaneal tubercle, which is the primary site of the fascia microtears. A high yield point is that the Windlass test is a key clinical maneuver. A passive dorsiflexion of the toes increases the tension of the plantar fascia, eliciting the pain in affected patients. A limited dorsiflexion, as the picture on the bottom right shows, can indicate a tight Achilles tendon, aka an equinus, that can also contribute to the underlying symptoms. Now, for the clinical diagnosis, the hallmark symptom is sharp, stabbing pain at the medial calcaneal tubercle, especially with the first steps in the morning or after prolonged sitting. Pain typically improves while walking, but worsens again with prolonged weight bearing. Physical examination reveals localized tenderness at the plantar fascial origin, right where the star shows in the picture. A positive Windlass test, as well as a possible limited dorsiflexion due to a tight Achilles tendon. While plantar fasciitis is a clinical diagnosis, imaging may be useful in selected cases. For example, X-rays can rule out calcaneal stress fractures but are not diagnostic of plantar fasciitis. A heel spur, commonly seen on an X-ray, is an incidental finding but does not correlate with symptom severity. Ultrasound, on the other hand, is a preferred modality due to its cost effectiveness and the ability to show a plantar fascia thickness greater than 4 mm, which is an indicative of a chronic fasciopathy. MRI is reserved for cases where other diagnoses such as stress fractures, soft tissue mass, or tarsal tunnels are suspected and needs to be further evaluated. It is essential to distinguish plantar fasciitis from other causes of heel pain. Stress fractures typically worsen with activity and do not improve with walking. Tarsal tunnel syndrome presents with burning pain and paresthesia along with medial plantar nerve distribution, often with a positive Tenel sign. Insertional Achilles tendinopathy affects the posterior heel, unlike plantar fasciitis. And fat pad atrophy, commonly seen in older adults, leads to diffuse heel pain without point tenderness at the plantar fascia origin. Now for non-surgical approaches. The first line approach to plantar fasciitis is conservative treatment. Stretching exercises for the Achilles tendon and plantar fascia are the most evidence-based intervention, as tightness contributes significantly to the pathology. Patients should modify activities levels by reducing high impact activities and using proper footwear with arch support. Orthotics, particularly prefabricated or custom insoles, help redistribute plantar loads. Nice splints are effective in chronic cases, maintaining dorsiflexion and preventing contracture of the plantar fascia. NSAIDs can provide short-term pain relief but have limited efficacy in long-standing cases due to the degenerative nature of the condition. So the best stretching protocol is usually 3 times a day. You want to do 10 reps per stretches and holding for about 20 to 30 seconds. And for the most effective orthotics, you want to have a soft, full-length insoles rather than a rigid custom one. And going further with the non-surgical treatments, for refractory cases, more advanced treatments may be considered, such as corticosteroid injections, which provide short-term relief but carry a risk of plantar fascia rupture if they are overused. Extracorporeal shockwave therapy, or ESWT, have been shown to stimulate tissue healing and is particularly beneficial for chronic cases. PRP therapy is another regenerative option using autologous growth factors to promote collagen synthesis. And the 10X procedure is a minimally invasive ultrasound guided technique removing degenerative tissues with minimal recovery time. It is important to note that steroid injection risks are about 10%, and with shockwave therapy success rate, there's about 70% improvement in chronic cases. The surgical aspect of this, usually reserved for cases that failed at least 6 to 12 months of conservative management. A partial plantar fasciotomy releases tension but must be performed carefully to avoid arch collapse. A gastrocnemius recession is indicated in patients with significant equinus deformity, addressing the underlying biomechanical contributor. An endoscopic technique offers quicker recovery compared to the open surgery. Rehabilitation, which is very crucial for preventing reoccurrence. Patients should begin gentle stretching and strengthening exercises early in the recovery. A gradual return to activity is advised, typically within 6 to 8 weeks for non-surgical cases and around 12 weeks post-surgery. Proper footwear and ongoing orthotics use help maintain long-term relief. But it's important to note the most common rehabilitation mistake is the resuming high-impact activities too soon. Stay tuned for part 2, where we will go over the surgical techniques and approaches for doing plantar fasciitis in details.